As we see, this presentation is titled with "It's Time to Think Broad and Holistic." The presentation is going to be very simple, and I believe it will add nothing new but some new direction of rethinking. We're going to combine new concept and dealing with clinical cases and mind new approach of tackling such cases either individual or in community. So, since the crux of this presentation is how to picture out and how to explicate how important is thinking broad and holistic could impressionably affect the way we should deal with different medical conditions effectively, so we're going to discuss the different concepts in medical practice in a case of diarrhea. Uh, as we see, this is a girl, 2 years old. She was complaining of severe diarrhea with very high frequency and very high frequency of vomiting. It was expected that her mother should take her immediately at once, immediately at the time the girl started to complain, to the nearest health facility. But unfortunately, the mother moved to the nearest health facility and take care here. That one was 25 kilometers far away of the residence of that girl. When after 5 days, not at same day, not second or third or even fourth day, after 5 days of starting the condition, when she went to that health center, the physician examined her. He found that signs of dehydration, just like, for example, sunken eye globes, dry skin, dry lips, dry mouth and tongue, and whatever the signs of dehydration. Pulse rate was expected to be very high, more even than 160 or even 170, especially she is very young. Blood pressure is expected to be very low. Respiratory rate is expected to be very high. Stool analysis, whatever the organism, bacteria or viral or whatever, and serum electrolytes, as expected, were found to be very, very low: sodium, potassium, and chloride. Actually, the treating physician has tried very hard to treat the girl and rehydrate her, but unfortunately, the girl passed away. Here, we cannot accuse or condemn the physician as a headless or rookie one. On the contrary, he handled the case very seriously and dealt prudently and harsh with the case. Without any shadow of doubt, the death of the poor girl was an act of God. No one can deny this fact. But at the same time, we should watch out the manner of the mother in dealing with such serious condition. What she had done was a misdeed, reckless, careless act. The mother was expected, as I told before, to pursue it immediately. Since the first day of her daughter started to complain, no doubt this great misdeed was of great concern in such death. Now, okay, now we have to step forward looking for the surrounding circumstances of such poor deceased girl. As we see here, the family is very large. As they seem, it's a very poor family. Number of siblings here are 8. Most of them are girls, as we see. Second serious point is or was the grandmother told the mother to stop feeding her child completely during diarrhea, which is very bad advice. As we have seen before, there was no health facility in the village. The mother had to move to the nearest health facility, which was 25 kilometers away from the residence. And the mothers couldn't go in the night or even in the day. The girl started to complain, excusing by she was looking after other children. Where's the husband, or where's the father? He's not available. He's busy. He is a drunken husband. Mother walks to nearby hospital 25 kilometers away. So all the circumstances are very bad. So when we examine that case again, the family was found to be big one with 8 siblings, and as we have said before, most of them were girls. Girls here are considered as invaluable in this culture or in those communities. So the mother wasn't in a hurry to move her girl immediately to the health facility, and which already was far away with the resistance. As I told you many times, it was 25 kilometers away. At the same time, the mother had excused, as we have seen, that the delayed movement to the health facility was because she was busy and looking after the other children, which really was an ugly and morally unaccepted excuse. On the other hand, in addition, the grandmother unintentionally had mystified the mother with a bad and wrong advice that was to stop totally feeding of this girl. Definitely, this misadvice also had another extra burden on the deterioration of the poor girl. Again, the father was unavailable. He was busy. He was drunk. His family means nothing in his mind. Now we can see that all the surrounding circumstances had served strongly the death of the poor girl, and even more the death of others is coming one by one. Okay, what's clear and very apparent here is our health is not affected just only by single factor or single agent. So we can ask ourselves, what affects our health? Many. Age, gender, individual lifestyle, social and community networks, general socio-economic, cultural, environmental conditions. So we can conclude also that improving health outcomes in any community requires more than just medical health services. We need a new level of insight into all the factors that contribute to one's health or person's health. So care is not just only medicine, but the food we eat, the water we drink, and the healthy activities we participate in our lives. So services that play a role in holistic health programs include nutritional counseling, exercise programs, and mindfulness activities such as meditation and yoga. For example, I'm just only giving examples. Let's say that, for example, doctors have increasingly realized that there are important connections between mental and physical health, which is why mental health care and support, for example, support groups, are another vital component of the holistic approach. So again, what affects our health? Many. What we eat, what we drink, what about the house we live in, what about the community services, what about the health services surrounding us, and so on. It's many. Okay, the question that comes now in our mind, do all the pre-mentioned factors exist in the medical system? No doubt that the unavailability of new medical facility, poor nutritious states with malnutrition, and the poor hygienic level of living conditions are all existing within the responsible medical system. But what about the big family number and wrong beliefs and practice with gender discrimination and prejudice of a male or against female child? Can we consider it as a defective medical system? Yes. while considering that this has led to lack of care given to the girl, the answer is big yes, because health education and trying to mend the wrong social and health beliefs of those population is a master key responsibility of health authority. Sure, poverty, illiteracy, and transport are all responsibilities of other organizations outside health authority. Now, substantially, there are three concepts of any disease causation. The first one is the traditional biomedical concept. It's based on germ theory, stating that almost any disease could possibly be due to causative agents that might be bacteria, virus, fungus, or whatever the organism. This is the first concept or first theory. Second one has a broader insight, seeing that or by the end, the causative agents are not so sufficient to cause a disease, and other surrounding socio-economic factors should exist to worsen or to make it worse. I mean here the disease, like for example, as we mentioned before, the poverty, what we eat, what we drink, lack of hygiene, are we illiterate or educated, do we have jobs or not, and so on. This concept is called socio-epidemiological concept. Okay, now we are sure that both concepts are there. We confess that there is a causative agent of the disease, flared up by many socio-economic factors. So what comes to our mind now the question is, what was the role of the government? Did they have designed policies to defeat such factors? Are such policies actually in action? I mean here, are they enacted? Ultimately, does the government take on its responsibilities to overcome such medical problems in such communities? This is what we call the political developmental concept. Here we come to a crossroad. Which way is favorable and could be constructive in approaching any medical condition? Each way has its own direction in dealing with the medical problem and thinks it's ideal. Each one thinks about himself is ideal. At the same time, no one has the right to confiscate or forfeit the vision of the other way. We have to respect each other. No question that both ways should join into one way, because the virtual aim by the end is the benefit of the patient. But the problem is the two ways are completely different. Here the clinician is dealing with a single person who is already deceased, and the efficient job here is rapid diagnosis and treatment of such patient, focusing mainly during such work on his patient's rights. Only the patient just in front of him, with no considerable or no consideration of either his family or even his or her neighbors or community, only the patient. The outcome here is almost either immediately after 1 or 2 days, or after a very short time, such as 1 week or 2 weeks, for example. The physician here is trained to focus on biology, physiology, pathology, and so on, and usually loves to speak about controlled, doubt-blind trials in treating patients. So, the tenet here in that way or in that direction is just diagnosis, treating, then moving rapidly to another patient. This is a way of thinking. It's adopted by, as we know, the clinician. The second way, on the other side of the story, as we see the patient here, is whole community, where the good work is prevention and control of epidemics, for example, with a great concern on environmental justice, not only the patient or not only to a single patient. And the outcome here is not immediate, but takes long time, as we see now, considering the disaster of COVID-19. We're still living in for more than 3 years now. So usually the public health workers are concerned with epidemiology, sociology, economics, and so on, with a tenet and creed which is completely different from the first one. The tenet or creed here is prevention, promotion, and protection of entire commonly, not only single patient, not only treating, diagnosing, treating, and dismissing patient to see the other one, but here I'm trying to prevent, promote, and protect the entire community. Just only to remind ourselves, are we practicing public health or community health, community medicine, population health, or global health? Just I'm sure that all of you know better than me, but just only to remind ourselves what are practicing here. Is it public health? As we know, the public health promotes and protects the health of people and the communities where we live or where they live, where they learn, work, and even where they play, even in the clubs, with tending to be focused on creating conditions in which individuals can be healthy. So, public health, as we know, usually focuses primarily on large-scale concerns or on the threats and dangers, as for example, vaccination, disease prevention, combating infectious disease, quitting smoking, quitting alcohol, especially those programs directed to teens and adults. Also in public health, we are interested about air quality education for asthmatics, for example, injury and illness avoidance, and so many programs. Okay, what about the community health? Here, the government is responsible for addressing and studying the social and economic determinants of health take care here, in somewhat localized area that can prevent people in such localized area from attaining and maintaining positive health outcomes. So I believe it's similar to public health, but tends to be more strictly geographically based, more strictly geographically localized, with more broad and holistic vision to healthy living. Community health often, as I believe, you may know better than me again, community health often tackles a broad spectrum of issues, such, for example, influencing public policy or creating shared community researches. Definitely, it's clear from the name, community medicine. It provides comprehensive health services ranging from preventive services, promoting services, curative services, rehabilitative services. So it's concerned here on, or concerned with early diagnosis of disease through what we know as screening, recognition of the environmental and occupational hazards to good health, and finally, the prevention of disease in the community. So, what about population health? The approach here utilizes take care, please. The approach here usually is using non-traditional partnerships among different sectors of the community. Here I mean the different sectors who may be partners or sharing in community health, public health, industry, academia, healthcare, local governmental entities, and so on, to achieve positive health outcomes. Population health usually brings significant health concerns into the focus of concerns. Again, population health usually brings the significant health concerns into the center or into the focus of concerns of many authorities, and addresses ways that resources from every source or from every authorities in such country or in such community should be allocated and used to overcome the problems that drive poor health conditions in the population. So, population health is about creating a collective sense. Again, population health is mainly concerned with collective or creating collective sense of responsibilities across all the organizations and authorities, and even individuals, in addition to public health specialties. Finally, the global health, we can understand that in the age of globalization, which becomes now not recent, global public health is one of the foremost challenges facing humanity. Not only one nation, not only one coalition of nations, but all the humanity, all the globe. That's because, as we know, global health is not just the work of massive governmental agencies or international global health organizations, but of people in communities, doctors, nurses, educators, volunteers, and advocates. Everyone in every country, in every community, in every single country. Fighting diseases and spreading health throughout the world is one of the most important missions now the human race can undertake in the 21st century, as we see the disaster of, for example, COVID-19. And with modern medicine, communication, and technology, it's within our reach now. If we ask ourselves, global health versus public health, global health is it's partly just a matter of location. Global health workers do the same work in the same way that domestic public health workers do. That means in the field, making the direct contact with communities, providing medical care to underserved population, educating people about disease prevention and treatment, and working to alleviate the systemic causes or factors of illness, such as, for example, poverty, racism, and oppression. But this is practiced and exercised on a very big scale. I mean here, globally. Now we come to the new title, which is One Health, One Planet, One Future. As we know, human populations are growing and expanding, becoming more large, and expanding into new geographic areas which may be inhabited by different animals, wild animals, or characterized by existing of strange plants. So as a result, more people live in close contact with wild and domestic animals, both livestock, pets. So animals play an important role in our lives, whether for food, for in livelihoods, travel, in sports, in education, or anywhere. So it's well known now that close contact with animals and their environments provides more opportunities for diseases to pass between animals and people. The movement of people, animals, and animal products has increased from international travel and trade. As a result, diseases can spread quickly across borders and around the globe. So One Health here is a collaborative, multi-sectoral, and transdisciplinary approach, working at the local, at regional, at national, and at global levels, with the goal of achieving optimal health outcomes to all, recognizing the interaction or the interconnection first between people, animals, and plants, and their shared environment, then providing holistic approach for providing health facilities for all. One Health is an approach that recognizes that the health of people is closely connected to the health of animals and our shared environment. Now to conclude the differences, the many differences between public health model and medical model, it's very easy, quite easy now. Uh, Considering the location of health action in the public health, it's whole community. In clinical medicine, it's just only the health facilities, either private clinic or hospital. The time scale of action is very long in public health, where it's immediate or short time in clinical practice. The sector in public health, it's many, it's multi-sectorial, while in the clinical medicine, just only the health sector. The focus of attention in public health is population, whole population, which is the denominators, while the clinical medicine is just only individuals forming the numerators. It's clear that the principal objectives here in the public health is disease prevention and control, while in clinical medicine, it's disease management, diagnosis, treatment, rapid turnover to another patient. Visibility of results are very low. Nothing obvious happens for individuals, while it's very high in clinical medicine, saving lives, for example. The consequences of public health profile financing is very low, while it's very large or very big or many in the clinical medicine. Stats among doctors, it's very low in public health, while in clinical medicine it's high. Profile in politics, public and media, what you are expecting, it's very low concerning public health and very high in clinical medicine. So the differences seem to be very finally, the gap in between both ways or both directions, there's a gap. There's a clear gap in beliefs and actions that should be minded and mended or corrected. Uh, in the health profession, we know that hierarchy, public health is a poor, as we usually consider we can say that public health is a poor cousin of clinical medicine, or maybe they consider us like that. At the best regarded as worthy but dull, and that worth has lacking in intellectual merit. We are not just like, for example, brain surgery or even general surgery. This for sorry. Specialization in clinical medicine leading to providing ever more complex care to an ever smaller numerator, which are patients, while public health evolves towards promoting interventions potentially benefiting an ever larger denominator. Here they are the population, but perhaps beyond the scope of health sector. So the conflict here or the gap here coming from two different schools. They are coming from two different schools. So the differences are in vision, in mission, in values, in focus, in scale, even in ethics, even in education, even in nature of science training. The question here, should it be, I mean the gap, should it be challenge or conflict? Definitely the answer no. No doubt there should be no challenge nor conflict. Why? Since both are targeting to serve the people and healthy population is on the top of their interest. Again, finally, both of such persons are targeting or are working for the benefit of patient, either single patient or the whole community. So now the problem here is how to convince both of them to work hand in hand, to work together, and to respect the way of each other. Considering that unfortunately existing gap in between two procedures or two ways of thinking and approaching cases, we have to ask ourselves, was the death of that girl, was it preventable? Definitely the answer is yes. Again, as per we said before, improving health outcomes in any community requires more than just medical health services. We need a new level of insight into all the factors that contribute or may be behind the person's health or maybe behind the illness or disease. Again, care is not just medicine, but the food we eat, the healthy activities we participate, and the programs that might be provided by health authorities or whatever, nutritional counseling, alcohol stopping, smoking, quitting, and so on. So, if we are enthusiastic and eager to succeed in our profession, we have to adopt another prudent and sensible approach in handling different health conditions. We have to follow new approach, gathering both ways of thinking together. We have to disregard the old narrow vision of considering health problem as only diagnosing and treating individual case with pretending that this is an ideal and great job. No, it's not. We should mind everything. We should mind every single issue relevant to the condition. We must dissect the condition. Again, we must dissect any condition we confront. This is what we call holistic vision. Now we have to start thinking about how to integrate public health approach with clinical medicine practice. Usually I consider it as raw nerve area. It's very irritating. Anyhow, we have to try. Okay, since we made an agreement before that there's a cross-cutting area between PH, public health, and PHC, primary health care, which is the patient's benefits. So I believe that we have to exert a lot of effort to how to bridge that gap as soon as possible. Uh, since the health organizations are usually adopting different team-based care models, clinical and public health or community or wherever, and are looking to achieve better outcomes and improve patient satisfaction, it will be essential to have a collaborative approach between both to address how practice teams function and partner with each other with adequate understanding. So, it's very important. It's of utmost importance to enhance the reciprocal and joint understanding. Reciprocal understanding of public health principles among physicians in the clinical field and enhancing understanding of clinical medicine principles among public health physicians. Reciprocal understanding of both sides usually appears to be an important attribute for better approach, definitely, that will lead to improved care of patients. This is our ultimate goal or our ultimate target. And even more may be relevant to improving overall performance of all teams, physicians and public health workers, nurses, and so on. This appears to be an important element of care implementation and the ability to move to more patient-centered model of care in addition to community-centered model of care. Again, this point is very important. The collaborative actions in between the clinicians and public health physicians usually move to more patient-centered model, which is the aim of physician of care, in addition to ours, which is community-centered model of care. But the gigantic or the big problem is that the whole body of public health scope of action is underestimated with an arrogance and superiority even from our colleagues. And sometimes we have to pay even a lot of effort to explain to them the vast importance of our branch, even to our physician friends. This is a predicament. Again, the second important approach in bridging the gap that should start as soon as possible between public health and clinical medicine practicing is trying to bridge the gap in joint researches. There must be a lot of joint researches in between two scopes of action. Research at the interface of clinical medicine and public health can improve individual patient and population health outcomes totally, particularly, especially with focusing on health disparities and other population level research. For example, in many researches, systematizing clinical data collection on all patients with certain disease was found to be associated with considerable decrease in complications of that disease, illustrating the power of data collection in the absence even of other intervention. As we see here, there is a commonalities between clinical medicine and public health, which usually the disease control, quality of care, research ethics, guidelines, training, and management. So, in integrating the clinical and public health knowledge in support of joint medical practice, how should it run? For example, the GPs, general practitioners, are expected to practice community medicine. Also, on the other side, public health physicians should be acquainted with clinical practice and should have some clinical training. Hospital specialists can be involved in disease control. It's not only can be, they should be involved in disease control and health service organizations. Clinicians should interpret protocols with reference to clinical epidemiology. They have to learn about epidemiology. Public health physicians should tailor preventive medicine to individual health risk. That's what I mean by reciprocal understanding and sharing. Also, during bridging the gap in between both approaches, there are 5 principles are essential for successful integration of PHC and public health. There must be a shared goal. A shared goal of both specialty must exist, which is population health improvement. It should be, the shared goal must be population health improvement. That should be the keystone of such collaboration. Second, community engagement in defining and addressing population health needs. The different authorities in the community should share in identification and addressing population health needs and areas in need of amendments and more care. Third, leadership who are responsible for running such disciplines, programs, and jurisdictions to decrease the fragmentation of medical and health services. This is the aim of leadership. In addition to foster continuity and permanence of such a bridging process, whether programs or policies or whatever, leaderships are also required to clarify rules for each partner. Also, to ensure accountability, they have to provide, develop, and support appropriate incentives. And by the end, such leadership should be ready for and have the capacity to manage any change at any time. Fourth, the established shared infrastructure required for enduring value and enduring change and impact in such trials of bridging such gap is eventually in need of some sort of continuity or sustainability for this gap not be rewidened again. Finally, The sharing and collaborative use of data and analysis should be considered for success of this interactive relationship. Such data definitely should be considered a private, shouldn't be considered a private property and should be there for each partner. No one can or should consider the data as a private property. It's a common in between all the partners. Uh, the factors influencing collaborative action or collaboration between public health and primary care, we can classify them into three main pillars: systemic factors, organizational factors, interactional factors. First, the systemic factors: how strong the government is holding its responsibility in such amendment of health system. Then, how far is fitting the implemented services and how appropriate to the local needs of each area, I mean here each geographical area. Then the sufficiency of the required resources, whether human resources or fiscal resources or whatever that are provided by the government. Then the adequate power of the government to command or to command every step in this collaboration. Finally, the education and training, as we have discussed before. Considering the organizational factors, there must be a common agenda settled by the local authority to be followed by all, otherwise failure will be the end result. Second, knowledge, leadership, resources, and accountability of the local authority should be considered, as we said before. The geographic proximity of the patient is very important for an easy contact, for an easy communication, and for an easy exchange of experiences. Again, same agenda, same protocols, and sharing information is of paramount importance at the organization level. Interactional sectors, shared purpose, again, philosophy and beliefs, clear roles and positive relationship, effective communication and decision-making strategy, nearly the same. To prepare future clinicians to assume their role in 22nd century health systems, many sites in the world, clinical public health curricula were established by many schools, for example, many schools of public health, like, for example, George Washington University School of Medicine and Health Sciences in USA, and University of Toronto Dalla Lana School of Public Health in Canada, and many other schools all around the world. No doubt that the clinical public health curricula integrate the following into the medical education throughout students' medical education, like public health, social determinants of health, community and population health, health system organization and management, healthcare policy, prevention and control, evidence-based practice, community service and engagement, interprofessional teamwork, leadership skills, in addition to clinical promotion. The trained physicians will not only be excellent clinicians for individual patients' health needs, but they will also be able to identify, understand, and address the community health issues, both within and beyond the walls of his clinic, either private clinic or in a hospital. Again and again and again, the benefits are on both sides and reciprocal for both sides. For example, prompt diagnosis and effective treatment with favorable outcomes for the patients will eventually add favorable outcomes for public health. In addition, favorable outcomes for all the community where the public health are already concerned with the efforts to improve. On the other hand, or on the other side, the efforts exerted by public health workers will prevent and control any health problems that may add to the burden and loads over the backs of clinical medicine. Finally, the question is, how should we think? Should we think public health or community health, or should we think community medicine or population health or global health, or should we think clinical medicine? Eventually, we have to think about all these threats. Speaking here about threats to the overall health of the community, so addressing the determinants of health across population rather than advocating for individual behavior changes. Uh, Thinking about all the threats that may be due to either germs, socioeconomic, or political developmental factors, the three concepts we have discussed before. Second, either uh, threats coming from insects, from animals, from plants, or whatever. Third, either inside or outside the community, in or out factors, and either national factors or transborder coming from countries abroad. And here we mean the global health. Last slide in that long presentation. It's a statement integrating clinical and public health in support of joint medical practice is the jackpot in our field. It's the great prize in our field. Finally, I hope the presentation wasn't boring. Again, I'm sure that I didn't add any new information, but I hope I could grab your attention to take hold of that thinking broad and holistic. Even more, this approach is fitting all the problems, not only the scientific problems. For example, just like social problems that we always facing in our lives. At last, wish you all the best and good luck.